infections. T cells are responsible for cell-mediated immunity, which includes recognizing and destroying infected cells and coordinating other immune responses. B cells produce antibodies that help neutralize pathogens and facilitate their elimination. In SCID, the lack of functional T and B cells means that the body cannot mount effective immune responses, resulting in increased vulnerability to infections. Common infections in SCID patients include pneumonia, meningitis, and infections from opportunistic pathogens, which typically do not cause disease in individuals with normal immune function. Diagnosis of SCID can be made through various laboratory tests, including measuring the levels of T and B cells in the blood, assessing the functionality of these cells, and genetic testing to identify specific mutations. Newborn screening for SCID has become increasingly important as early detection can lead to life-saving interventions. Treatment options for SCID include hematopoietic stem cell transplantation, HSCT, which can restore the immune system by providing healthy stem cells from a matched donor. This procedure has been successful in many cases, allowing affected individuals to develop functional immune systems. In addition to stem cell transplantation, other treatments may be considered based on the underlying cause of SCID. For instance, enzyme replacement therapy can be used for patients with adenosine deaminase deficiency, one of the forms of SCID. Supportive care, such as prophylactic antibiotics and immunoglobulin replacement therapy, is also essential to manage infections and provide some level of immune protection until definitive treatment can be administered. Understanding the mechanisms and clinical implications of SCID is crucial for medical students, as it emphasizes the importance of the immune system in overall health and the need for timely interventions in immunodeficient patients to prevent severe complications. X-linked agammaglobulinemia, XLA, is a genetic disorder characterized by the absence or significantly reduced levels of immunoglobulins, which are antibodies that play a critical role in the immune response. This condition is primarily caused by a mutation in the BTK gene, Bruton's tyrosine kinase, located on the X chromosome. The BTK gene is essential for the development and maturation of B lymphocytes, B cells, which are responsible for producing antibodies. As a result, individuals with XLA have a severely impaired ability to produce functional antibodies, leading to increased susceptibility to infections. In XLA, the mutation in the BTK gene disrupts the signaling pathways necessary for B cell development in the bone marrow. Normally, B cells undergo several stages of maturation, and one of the critical steps involves the successful rearrangement of immunoglobulin genes to produce unique antibodies. The BTK protein is crucial during this process, as it helps transmit signals that promote B cell growth and differentiation. When this signaling pathway is disrupted due to the mutation, B cells fail to mature properly, leading to a significant reduction in the number of circulating B cells and, consequently, the absence of immunoglobulins. Individuals with XLA typically present in early childhood, often after 6 months of age when maternal antibodies start to decline. They experience recurrent bacterial infections, particularly from encapsulated organisms such as Streptococcus pneumonia and Haemophilus influenzae. These infections can manifest as pneumonia, sinusitis, and ear infections, which are common in young children. Because individuals with XLA produce very few antibodies, they lack the ability to effectively neutralize and clear pathogens from their bodies, resulting in chronic and severe infections. Diagnosis of XLA involves a combination of clinical evaluation and laboratory tests. Affected individuals typically show very low or absent levels of serum immunoglobulins, IgG, IgA, and IgM, and a significant reduction in circulating B cells. Genetic testing can confirm the presence of mutations in the BTK gene, providing a definitive diagnosis. It is important to differentiate XLA from other forms of immunodeficiency, as early identification is crucial for effective management. Treatment for XLA primarily focuses on providing the missing antibodies to help prevent infections. This is typically achieved through regular intravenous immunoglobulin, IVIG, or subcutaneous immunoglobulin, SCIG therapy, which supplies the patient with immunoglobulins from healthy donors. These treatments help boost the immune system and reduce the frequency and severity of infections. Additionally, prophylactic antibiotics may be prescribed to help prevent bacterial infections. Understanding X-linked agammaglobulinemia is essential for medical students as it underscores the importance of B cells in the immune response and highlights the significance of timely diagnosis and management in preventing complications associated with immunodeficiency. Common variable immunodeficiency, CVID, is a primary immunodeficiency disorder characterized by a significant reduction in immunoglobulin levels, leading to an increased susceptibility to infections. Unlike X-linked agammaglobulinemia, which typically presents in early childhood, CVID can be diagnosed at any age, often in late childhood or adulthood. The exact cause of CVID is not fully understood, but it is believed to involve a combination of genetic and environmental factors that affect B-cell function and antibody production. In CVID, individuals have low levels of immunoglobulins, IgG, IgA, and IgM, which are essential for mounting an effective immune response against pathogens. The disorder is primarily associated with dysfunction in B lymphocytes, which are responsible for producing antibodies. In healthy individuals, B cells differentiate into plasma cells that produce specific antibodies in response to infections. However, in CVID, this differentiation process is impaired, leading to reduced antibody production and a diminished ability to fight off infections. Patients with CVID often experience recurrent infections, particularly respiratory infections caused by encapsulated bacteria such as Streptococcus pneumonia and Haemophilus influenzae. They may also be susceptible to gastrointestinal infections, viral infections, and opportunistic infections. In addition to increased susceptibility to infections, individuals with CVID can experience complications related to autoimmune diseases, lymphoproliferative disorders, and gastrointestinal issues such as chronic diarrhea or inflammatory bowel disease. Diagnosis of CVID typically involves measuring serum immunoglobulin levels, which reveal low levels of immunoglobulins. Additionally, tests may be performed to assess the functionality of B cells and their ability to produce antibodies in response to vaccines. Genetic testing may also be conducted to identify specific mutations, although no single genetic cause has been definitively linked to CVD. A thorough clinical evaluation is essential to rule out other immunodeficiency disorders and to confirm the diagnosis. Management of CVD primarily focuses on providing replacement therapy with immunoglobulin to help boost the immune system and reduce the risk of infections. This can be administered through intravenous immunoglobulin, IVIG, or subcutaneous immunoglobulin, SCIG therapy. In some cases, prophylactic antibiotics may be prescribed to prevent infections. Regular follow-up and monitoring are important to address any complications that may arise, such as autoimmune conditions or the development of lymphomas. Understanding common variable immunodeficiency is crucial for medical students as it emphasizes the importance of B-cell function in immune defense and highlights the need for comprehensive care in managing patients with immunodeficiency disorders. Immunoglobulin A, IgA, deficiency is one of the most common primary immunodeficiency disorders, characterized by the absence or significantly reduced levels of IgA in the blood and secretions. IgA is an antibody that plays a crucial role in mucosal immunity, helping to protect mucosal surfaces, such as those found in the respiratory and gastrointestinal tracts, from infections. While individuals with IgA deficiency may have normal levels of other immunoglobulins, IgG and IgM, the lack of IgA can lead to increased susceptibility to infections, particularly those affecting mucosal surfaces. The exact cause of IgA deficiency is often unknown, but it is believed to have a genetic component, as it can sometimes run in families. The condition can occur as an isolated deficiency or as part of other immunodeficiency syndromes. In IgA deficiency, the B cells responsible for producing IgA do not function properly, leading to reduced antibody production. This deficiency can result from various factors, including abnormalities in B cell differentiation and signaling pathways that affect the immune response. Individuals with IgA deficiency may be asymptomatic and may not experience any significant health issues. However, many affected individuals face recurrent infections, especially respiratory tract infections, such as sinusitis, pneumonia, and bronchitis. They may also be more prone to gastrointestinal infections and allergies. Interestingly, some individuals with IgA deficiency can develop antibodies against IgA, which can lead to complications if they receive blood products containing IgA, as this can trigger severe allergic reactions. Diagnosis of IgA deficiency typically involves measuring serum immunoglobulin levels, which will show low or absent IgA levels while other immunoglobulins remain normal. It is essential to rule out secondary causes of IgA deficiency, such as certain medications, infections, or other underlying conditions that may affect the immune system. A thorough clinical history and evaluation are important to assess the patient's immune status and identify any recurrent infections or associated conditions. Management of IgA deficiency primarily focuses on monitoring the individual's health and addressing any recurrent infections or complications that may arise. Patients are often advised to maintain good hygiene practices and receive vaccinations to help prevent infections. In cases where recurrent infections become problematic, prophylactic antibiotics may be prescribed. While there is currently no specific treatment to restore IgA levels, understanding IgA deficiency is essential for medical students, as it highlights the importance of mucosal immunity and the need for comprehensive care in patients with immune system disorders. Hyper-IgM syndrome is a rare immunodeficiency disorder characterized by elevated levels of immunoglobulin M, IgM, and low levels of other immunoglobulins, particularly immunoglobulin G, IgG, and immunoglobulin A, IgA. This condition results from a defect in the immune system's ability to switch from producing IgM to producing other types of antibodies, which are essential for effectively combating infections. Hyper-IgM syndrome can be inherited in several ways, with the most common form being X-linked, caused by mutations in the CD40 ligand, CD40L, gene on the X chromosome. The immune system relies on a process called class switching to produce different classes of antibodies in response to various pathogens. When B cells are activated, they initially produce IgM antibodies. However, with the help of T cells, particularly through interaction with CD40 and CD40L, B cells can switch to producing IgG, IgA, or IgE antibodies. In hyper-IgM syndrome, the mutation in the CD40L gene prevents effective communication between T cells and B cells, inhibiting this class-switching process. As a result, affected individuals produce excessive amounts of IgM, but have significantly reduced levels of other immunoglobulins, impairing their immune response. Individuals with hyper-IgM syndrome are highly susceptible to recurrent infections, particularly from encapsulated bacteria such as Streptococcus pneumonia and Haemophilus influenzae. These infections can manifest as pneumonia, sinusitis, and ear infections. Additionally, patients may experience opportunistic infections due to their compromised immune system. The lack of IgG and IgA limits the body's ability to mount effective immune responses, leading to increased vulnerability and more severe infections. Diagnosis of hyper-IgM syndrome involves measuring serum immunoglobulin levels, which will show elevated IgM and decreased IgG and IgA levels. Genetic testing can confirm the diagnosis by identifying mutations in the CD40L gene or other associated genes in non-X-linked forms of hyper-IgM syndrome, such as mutations in the AID, activation-induced cytidine deaminase gene. A thorough clinical evaluation is important to assess the patient's immune status and identify any recurrent infections or complications. Management of hyper-IgM syndrome primarily focuses on preventing infections and managing complications. This may include prophylactic antibiotics to reduce the risk of bacterial infections and immunoglobulin replacement therapy to provide the deficient antibodies. In some cases, hematopoietic stem cell transplantation, HSCT, may be considered as a potential curative treatment, particularly in patients with severe manifestations. Understanding hyper-IgM syndrome is crucial for medical students as it emphasizes the complexity of the immune system, the importance of effective class switching in antibody production, and the need for comprehensive care in patients with immunodeficiencies. Wiskott-Aldrich syndrome, WAS, is a rare X-linked genetic disorder characterized by a triad of symptoms: eczema, recurrent infections, and thrombocytopenia, low platelet count. This condition primarily affects males due to its X-linked inheritance pattern, meaning that the gene responsible for WAS is located on the X chromosome. The disorder is caused by mutations in the WAS gene, which plays a crucial role in the development and function of immune cells and platelets. The WAS gene is essential for the proper functioning of T cells and B cells, both of which are vital components of the adaptive immune system. In individuals with Wiskott-Aldrich syndrome, the impaired function of these immune cells leads to a reduced ability to fight infections. As a result, affected individuals are more susceptible to bacterial, viral, and fungal infections. Common infections include pneumonia, otitis media, ear infections, and skin infections. The immune deficiency is primarily due to the dysfunction of T cells, which are essential for coordinating immune responses and helping B cells produce antibodies. Thrombocytopenia in Wiskott-Aldrich syndrome is characterized by a low number of platelets in the blood, which can lead to bleeding and bruising. The WAS gene mutation affects the development of megakaryocytes, the cells responsible for producing platelets in the bone marrow. As a result, individuals with WWAS often experience symptoms such as easy bruising, petechiae, small red or purple spots on the skin, and increased bleeding after minor injuries. Severe cases can lead to life-threatening bleeding complications. Eczema is another prominent feature of Wiskott-Aldrich syndrome, typically appearing in infancy or early childhood. It manifests as itchy, inflamed skin and can be quite uncomfortable for affected individuals. The exact mechanism behind the skin manifestations is not fully understood, but it is believed to be related to the underlying immune dysfunction that also affects the skin's ability to respond to irritants and allergens. Diagnosis of Wiskott-Aldrich syndrome involves clinical evaluation, family history, and laboratory tests to assess immunoglobulin levels, platelet counts, and the presence of eczema. Genetic testing can confirm the diagnosis by identifying mutations in the WAS gene. Management of WAS includes supportive care, such as treating infections promptly, managing eczema, and monitoring platelet counts. In severe cases, hematopoietic stem cell transplantation, HSCT, may be considered as a curative treatment. Understanding Wiskott-Aldrich syndrome is essential for medical students as it highlights the interplay between immune function, hematology, and dermatology in a single disorder, emphasizing the need for a multidisciplinary approach to patient care. Complement deficiencies refer to a group of inherited or acquired disorders that result in the inadequate functioning of the complement system, a crucial part of the immune system. The complement system consists of a series of proteins that work together to enhance the ability of antibodies and phagocytic cells to clear pathogens from the body. It plays a key role in innate immunity, helping to opsonize pathogens for easier recognition and destruction, promoting inflammation, and directly lysing microbial cells. Deficiencies in any component of this system can lead to increased susceptibility to infections and autoimmune diseases. There are several types of complement deficiencies, each associated with specific components of the complement system. The most common deficiencies involve proteins such as C1, C2, C3, and C4. For example, C3 deficiency is particularly severe because C3 is central to the complement pathway, and plays a pivotal role in opsonization and the formation of the membrane attack complex. Individuals with C3 deficiency are at a higher risk of infections from encapsulated bacteria like Streptococcus pneumonia and Neisseria species. Other deficiencies, such as C1 inhibitor deficiency, can lead to conditions like hereditary angioedema, characterized by recurrent episodes of severe swelling. The complement system can be activated through three main pathways: the classical pathway, the lectin pathway, and the alternative pathway. Each pathway has distinct triggers but converges at the activation of C3. In classical activation, antibodies bound to antigens trigger the complement cascade. The lectin pathway is activated by the binding of lectins to specific carbohydrates on the pathogen's surface. The alternative pathway can be spontaneously activated on pathogen surfaces without antibody involvement. Deficiencies in any of these pathways can lead to clinical manifestations, primarily related to increased susceptibility to infections and potential autoimmune responses. Diagnosing complement deficiencies typically involves a combination of clinical evaluation, family history, and laboratory tests to measure complement levels and function. Specific tests can be performed to assess the activity of different complement components, such as the CH50 assay, which evaluates the overall functional capacity of the complement system. Genetic testing may also be employed to identify specific mutations associated with complement deficiencies, particularly in cases of inherited disorders. Management of complement deficiencies focuses on preventing infections and managing any associated complications. This may include prophylactic antibiotics to reduce the risk of infections, immunizations to protect against specific pathogens, and, in some cases, replacement therapy using complement components. For conditions like hereditary angioedema, treatment may involve medications that increase levels of C1 inhibitor or block its effects. Understanding complement deficiencies is essential for medical students, as it underscores the importance of the complement system in immune defense and highlights the need for comprehensive care in patients with immunodeficiencies. Systemic lupus erythematosus, SLE, is a chronic autoimmune disease that can affect multiple organ systems in the body. It is characterized by the production of autoantibodies that target the body's own tissues, leading to inflammation and damage. SLE primarily affects women, particularly during their reproductive years, but it can also occur in men and children. The exact cause of SLE is not fully understood. However, it is believed to result from a combination of genetic, environmental, and hormonal factors that trigger an abnormal immune response. In SLE, the immune system mistakenly identifies normal cells and tissues as foreign invaders, leading to the production of a wide range of autoantibodies. One of the hallmark autoantibodies in SLE is anti-nuclear antibodies, ANAs, which target the nuclei of cells. These autoantibodies can also include anti-double-stranded DNA and anti-Smith antibodies. The presence of these autoantibodies contributes to the formation of immune complexes that can deposit in various tissues, causing inflammation and damage, particularly in the kidneys, skin, joints, and blood vessels. The clinical manifestations of SLE can be diverse and vary widely between individuals. Common symptoms include fatigue, fever, joint pain, and skin rashes, such as the characteristic butterfly rash that appears across the cheeks and nose. Patients may also experience photosensitivity, leading to skin eruptions upon exposure to sunlight. In addition to these symptoms, SLE can affect the kidneys, lupus nephritis, causing proteinuria and renal impairment. Other potential complications include hematological issues such as anemia and thrombocytopenia, as well as neurological manifestations like seizures or psychosis. Diagnosis of SLE is based on a combination of clinical criteria and laboratory tests. The American College of Rheumatology has established criteria that include a range of symptoms and laboratory findings. Blood tests often reveal elevated levels of ANAs and other specific autoantibodies, alongside abnormalities in blood counts and kidney function tests. it's essential to perform a thorough clinical evaluation to differentiate SLE from other autoimmune diseases and to assess the extent of organ involvement. Management of SLE focuses on controlling symptoms, preventing flares, and minimizing organ damage. Treatment may include non-steroidal anti-inflammatory drugs, NSAIDs, for joint pain and inflammation, corticosteroids to reduce inflammation during flares, and immunosuppressive medications to manage severe disease and protect affected organs. Sun protection and lifestyle modifications are also important to reduce flare-ups. Understanding systemic lupus erythematosus is crucial for medical students, as it highlights the complexities of autoimmune diseases, the need for a multidisciplinary approach to patient care, and the importance of ongoing monitoring and management of chronic conditions. Sjogren's syndrome is a chronic autoimmune disorder primarily characterized by dry eyes and dry mouth, resulting from the immune system attacking the body's moisture-producing glands. This condition can occur as a primary disorder or secondary to other autoimmune diseases, such as rheumatoid arthritis or systemic lupus erythematosus. The exact cause of Sjogren's syndrome is not fully understood, but it is thought to involve a combination of genetic predisposition, environmental triggers, and hormonal factors that lead to an abnormal immune response. The hallmark of Sjogren's syndrome is the infiltration of lymphocytes, particularly CD4+ T cells, into the exocrine glands, especially the salivary and lacrimal glands. This infiltration causes inflammation, resulting in a decrease in the production of saliva and tears. As a result, individuals with Sjogren's syndrome experience xerostomia, dry mouth, and keratoconjunctivitis sicca, dry eyes. Dry mouth can lead to difficulties in swallowing, increased dental caries, and oral infections, while dry eyes can cause irritation, redness, and potential damage to the cornea. In addition to the primary symptoms of dry eyes and dry mouth, Sjogren's syndrome can affect other parts of the body, leading to systemic manifestations. Patients may experience joint pain and stiffness, fatigue, and swelling of the salivary glands, sialadenitis. Some individuals may develop complications such as lung issues, kidney problems, or neuropathy. Importantly, Sjogren's syndrome is associated with an increased risk of developing certain lymphomas, particularly mucosa-associated lymphoid tissue, MALT lymphoma. Diagnosis of Sjogren's syndrome involves a combination of clinical evaluation, laboratory tests, and imaging studies. A thorough history and physical examination are essential to assess symptoms and potential complications. Salivary flow tests, tear production tests, such as the Schirmer test, and specific autoantibody tests, including anti-Rho, SSA, and anti-LA, SSB, are often utilized to confirm the diagnosis. A lip biopsy may also be performed to check for lymphocytic infiltration in the salivary glands. Management of Sjogren's syndrome focuses on alleviating symptoms and preventing complications. Treatment options include artificial tears and saliva substitutes to relieve dryness, as well as medications such as pilocarpine and cevimeline to stimulate saliva production. Patients are also advised on good oral hygiene practices to prevent dental issues and may benefit from regular dental checkups. In cases of systemic involvement, immunosuppressive therapies may be indicated. Understanding Sjogren's syndrome is crucial for medical students, as it illustrates the complexities of autoimmune diseases and the need for a patient-centered approach in managing chronic conditions. Scleroderma, also known as systemic sclerosis, is a complex autoimmune disease characterized by the hardening and tightening of the skin and connective tissues due to excessive collagen production. This condition can affect not only the skin, but also internal organs such as the lungs, heart, kidneys, and gastrointestinal tract. Scleroderma primarily affects women, particularly in their 30s to 50s, but it can occur in men and individuals of any age. The exact cause of scleroderma remains unclear, but it is believed to involve a combination of genetic, environmental, and immunological factors that trigger abnormal immune responses. The pathophysiology of scleroderma involves three main processes: autoimmunity, vasculopathy, and fibrosis. Autoimmunity refers to the immune system's attack on the body's own tissues, leading to the production of specific autoantibodies, such as anti-SCL70 and anti-centromere antibodies. Vasculopathy involves damage to the small blood vessels, resulting in decreased blood flow and oxygen to the tissues. Lastly, fibrosis is the excessive accumulation of collagen and other extracellular matrix components, leading to the thickening and hardening of the skin and other affected organs. These processes contribute to the various symptoms and complications seen in scleroderma. There are two main forms of scleroderma: localized and systemic. Localized scleroderma primarily affects the skin and is often characterized by patches of thickened, hardened skin, such as morphea or linear scleroderma. In contrast, systemic scleroderma involves widespread skin changes and can significantly affect internal organs. Systemic scleroderma is further classified into two subtypes: limited cutaneous scleroderma, which has a milder course and primarily affects the skin of the face and extremities, and diffuse cutaneous scleroderma, which has a more aggressive course and can involve rapid skin changes and internal organ involvement. Clinical manifestations of scleroderma can vary widely among individuals, but common symptoms include skin changes such as tightness, swelling, and discoloration. Patients may also experience Raynaud's phenomenon, where the fingers and toes turn white or blue in response to cold or stress due to blood vessel constriction. Internal organ involvement can lead to pulmonary complications, such as interstitial lung disease or pulmonary hypertension, gastrointestinal issues like esophageal dysmotility, and renal complications resulting from scleroderma renal crisis. Diagnosis of scleroderma involves a combination of clinical evaluation, laboratory tests, and imaging studies. A thorough examination of the skin and assessment of symptoms are essential for diagnosis. Blood tests may be performed to identify specific autoantibodies associated with scleroderma. Imaging studies, such as echocardiograms, pulmonary function tests, and chest X-rays, can help evaluate organ involvement. Management of scleroderma focuses on alleviating symptoms and preventing complications, often involving a multidisciplinary approach that includes dermatologists, rheumatologists, pulmonologists, and other specialists. Treatment options may include immunosuppressive medications, vasodilators for Raynaud's phenomenon, and supportive therapies to manage specific symptoms. Understanding scleroderma is crucial for medical students, as it emphasizes the complexity of autoimmune diseases and the importance of comprehensive patient care. Mixed connective tissue disease, MCTD, is an autoimmune disorder characterized by features of several connective tissue diseases, primarily systemic lupus erythematosus, SLE, scleroderma, and polymyositis. It is often considered a unique entity, distinguished by the presence of specific autoantibodies, particularly anti-U1 ribonucleoprotein, RNP antibodies. MCTD typically affects young women, but it can occur in men and individuals of any age. The exact cause of MCTD remains unclear, but it is thought to involve a combination of genetic predisposition, environmental factors, and immune dysregulation. The pathophysiology of MCTD involves the abnormal activation of the immune system, leading to the production of autoantibodies that target various components of connective tissue. The presence of anti-U1 RNP antibodies is a hallmark of MCTD and indicates the involvement of ribonucleoproteins, which play a critical role in cellular processes such as RNA processing. This autoimmune response results in inflammation and damage to multiple organ systems, contributing to the diverse clinical manifestations associated with the disease. Patients with MCTD often present with a combination of symptoms that reflect the overlapping features of the related connective tissue diseases. Common symptoms include Raynaud's phenomenon, which involves episodes of finger and toe discoloration in response to cold or stress, as well as swelling in the hands and fingers, puffy fingers. Other manifestations may include joint pain and inflammation, muscle weakness, skin changes such as a rash or sclerodactyly, and pulmonary involvement that can lead to interstitial lung disease or pulmonary hypertension. Diagnosis of MCTD involves a combination of clinical evaluation, laboratory tests, and imaging studies. A thorough history and physical examination are critical in identifying overlapping features of different connective tissue diseases. Blood tests are performed to detect the presence of specific autoantibodies, with anti-U1RNP antibodies being the most indicative of MCTD. Other autoantibodies, such as anti-Smith or anti-SCL70, may also be present and can help guide the diagnosis. Imaging studies, such as echocardiograms or lung function tests, may be used to assess organ involvement. Management of mixed connective tissue disease focuses on controlling symptoms, preventing complications, and improving the patient's quality of life. Treatment often involves the use of nonsteroidal anti-inflammatory drugs, NSAIDs, to relieve pain and inflammation, corticosteroids to reduce immune activity during flares, and immunosuppressive medications for more severe manifestations. Patients are encouraged to engage in regular follow-up care to monitor disease progression and manage any complications that may arise. Understanding mixed connective tissue disease is essential for medical students, as it highlights the complexity of autoimmune disorders and underscores the importance of an individualized, multidisciplinary approach to patient care. Wound healing is a complex biological process that the body uses to repair damaged tissues following injury. It involves a series of overlapping phases: hemostasis, inflammation, proliferation, and remodeling. Each phase is essential for restoring tissue integrity and function, and can vary in duration and intensity depending on factors such as the type of wound, the individual's health, and the presence of any underlying conditions. The first phase, hemostasis, occurs immediately after an injury. The primary goal of this phase is to stop bleeding. When a blood vessel is damaged, platelets aggregate at the injury site and form a clot to seal the wound. This clot not only prevents further blood loss, but also serves as a temporary matrix for incoming cells. In addition, clotting factors released during this phase help to initiate the inflammatory response by attracting immune cells to the site of injury. The second phase, inflammation, typically begins within hours of the injury and lasts for several days. During this phase, immune cells, such as neutrophils and macrophages, migrate to the wound site to clear debris, bacteria, and dead tissue. This process is essential for preventing infection and setting the stage for tissue repair. Macrophages also play a crucial role in releasing growth factors and cytokines that promote the next phase of healing, which is proliferation. The proliferation phase is characterized by the formation of new tissue. This phase generally begins within a few days after the injury and can last for several weeks. Key processes include angiogenesis, the formation of new blood vessels, collagen deposition, and the migration of fibroblasts and epithelial cells to the wound site. Fibroblasts synthesize collagen, which provides structural support to the newly formed tissue. This new tissue, known as granulation tissue, is essential for supporting the healing process and eventually leads to tissue closure. Finally, the remodeling phase can continue for months to years after the initial injury. During this phase, the collagen fibers in the wound undergo reorganization and maturation, leading to improved tensile strength and stability of the tissue. The scar tissue formed may differ from the original tissue in terms of appearance and function, but the goal is to restore as much integrity as possible. Understanding the wound healing process is essential for medical students, as it emphasizes the importance of timely and appropriate interventions in managing wounds, the factors that can impair healing, and the body's remarkable ability to regenerate tissue in response to injury. Wound healing repair is a vital biological process that the body undergoes to restore tissue integrity after an injury. This process involves a series of coordinated steps that can be broadly categorized into four main phases: hemostasis, inflammation, proliferation, and remodeling. Each phase plays a critical role in ensuring that the wound heals effectively and efficiently, and understanding these phases is essential for medical students and healthcare professionals. The first phase, hemostasis, begins immediately after an injury occurs. The primary aim during this phase is to stop bleeding. When blood vessels are damaged, they constrict to reduce blood flow, and platelets, a type of blood cell, aggregate to form a clot. The clot acts as a physical barrier to prevent further blood loss and also releases signaling molecules that attract immune cells to the site of injury. This initial response is crucial, as it sets the stage for the subsequent inflammatory phase. The second phase is inflammation, which typically starts within hours of the injury and can last for several days. During this phase, immune cells, particularly neutrophils and macrophages, migrate to the wound site. Neutrophils are the first responders, working to clear debris and bacteria, thus preventing infection. Macrophages follow, playing a dual role. They help clean up the wound and release various growth factors and cytokines that are essential for the next phase of healing. Inflammation is characterized by redness, swelling, heat, and pain, which are signs that the body is actively working to heal the wound. Next comes the proliferation phase, which usually begins a few days after the injury and can last for several weeks. This phase is focused on tissue formation and repair. Key processes in this stage include angiogenesis, the formation of new blood vessels, fibroblast proliferation, and epithelialization, the migration of skin cells to cover the wound. Fibroblasts produce collagen, a protein that provides strength and structure to the new tissue. Granulation tissue, which is rich in blood vessels and collagen, forms during this phase and serves as the foundation for new tissue development. The final phase of wound healing is remodeling, which can take months to years. During this phase, the collagen fibers in the wound undergo restructuring and reorganization. The goal of remodeling is to increase the tensile strength of the healed tissue, although the scar that forms may not possess the same strength or elasticity as the original tissue. The remodeling phase can lead to changes in the appearance of the scar, which may gradually become less noticeable over time. Understanding wound healing repair is crucial for medical students as it highlights the body's complex and dynamic response to injury. Factors such as nutrition, blood supply, age, and the presence of underlying health conditions can all influence the healing process. Recognizing the stages of wound healing helps healthcare professionals provide effective interventions and support to optimize healing and minimize complications in patients with wounds. Tissue regeneration and repair are essential biological processes that the body employs to restore damaged tissues after injury. While both processes aim to heal wounds and restore function, they differ in their mechanisms and outcomes. Regeneration refers to the complete restoration of tissue architecture and function, often seen in tissues with a high regenerative capacity, such as the liver or skin. Repair, on the other hand, usually involves the formation of scar tissue and may not fully restore the original tissue structure or function. Understanding these processes is crucial for medical students as they highlight the body's remarkable ability to heal and the underlying mechanisms involved. The first step in tissue regeneration and repair is the initial response to injury, which involves hemostasis. When a tissue is damaged, blood vessels constrict to minimize blood loss, and platelets aggregate at the injury site to form a clot. This clot not only acts as a physical barrier to prevent further bleeding, but also releases signaling molecules that recruit immune cells to the area. These immune cells play a vital role in clearing debris and bacteria, setting the stage for the subsequent phases of healing. Following hemostasis, the inflammatory phase begins, characterized by the recruitment of immune cells, such as neutrophils and macrophages, to the injury site. Neutrophils are the first responders, working to eliminate pathogens and clear dead tissue. Macrophages follow, playing a crucial role in orchestrating the healing process by releasing growth factors and cytokines that promote tissue repair and regeneration. They stimulate fibroblast proliferation and extracellular matrix, ECM production, which are essential for providing structural support to the newly forming tissue. In the proliferation phase, tissue regeneration occurs through several key processes. Fibroblasts migrate to the wound site and produce collagen and other components of the extracellular matrix. This newly formed tissue, known as granulation tissue, serves as a scaffold for further healing. Additionally, angiogenesis, or the formation of new blood vessels, occurs to ensure an adequate blood supply and oxygen delivery to the regenerating tissue. Epithelial cells also play a critical role during this phase, migrating to cover the wound and restore the protective barrier of the skin or mucosal surfaces. Finally, the remodeling phase follows proliferation, which can last for months to years. During this phase, the newly formed tissue undergoes maturation and reorganization. Collagen fibers are remodeled to increase tensile strength, and scar tissue is formed as a result. While the goal of remodeling is to restore functionality, the final scar may not completely replicate the original tissue's structure or function. Understanding the mechanisms of tissue regeneration and repair is essential for medical students, as it informs clinical practice regarding wound management, treatment strategies for injuries, and the potential for regenerative medicine approaches in healing damaged tissues. Wound healing is a complex biological process that can occur normally or aberrantly, leading to different outcomes. Normal wound healing involves a series of well-coordinated phases: hemostasis, inflammation, proliferation, and remodeling. In contrast, aberrant wound healing refers to situations where the healing process is disrupted, leading to complications such as chronic wounds, excessive scarring, or other disorders. Understanding both normal and aberrant wound healing is crucial for medical students, as it can inform treatment strategies and improve patient care. Normal wound healing begins with hemostasis, where blood vessels constrict to minimize bleeding and platelets aggregate to form a clot. This clot serves as a physical barrier and releases signaling molecules that attract immune cells to the injury site. The inflammatory phase follows, characterized by the recruitment of neutrophils and macrophages to the wound. These immune cells help eliminate pathogens and debris, creating a clean environment for healing. Following inflammation, the proliferation phase begins, during which fibroblasts produce collagen and other components of the extracellular matrix, forming granulation tissue. This tissue supports new blood vessel formation, angiogenesis, and epithelial cell migration, ultimately leading to wound closure. In normal healing, the remodeling phase occurs after proliferation, where the new tissue matures and reorganizes. Collagen fibers are rearranged to improve the tensile strength of the wound, and the scar tissue formed becomes less noticeable over time. This entire process typically takes weeks to months, depending on the severity of the injury and the individual's overall health. Successful normal wound healing restores tissue integrity and function, allowing the affected area to return to its pre-injury state as much as possible. Aberrant wound healing can occur due to various factors that disrupt the normal healing process. Chronic wounds, such as diabetic ulcers or pressure sores, may arise when the wound fails to progress through the healing phases appropriately. Factors such as poor blood flow, infection, inadequate nutrition, or underlying medical conditions can impede healing. In these cases, the inflammatory phase may be prolonged, leading to persistent inflammation and further tissue damage rather than progression to proliferation and remodeling. Another form of aberrant healing is excessive scarring, or hypertrophic scars and keloids, which occur due to an overproduction of collagen during the healing process. While some scarring is a normal part of wound healing, excessive scar formation can lead to functional and aesthetic concerns for patients. Understanding the mechanisms of both normal and aberrant wound healing is vital for medical students, as it highlights the importance of identifying potential complications early and implementing appropriate interventions to promote healing and improve patient outcomes.